It gives me immense pleasure to extend a very warm welcome to our next speaker, Dr. Nikhil Tandon, Professor and Head of Department of Endocrinology, All India Institute of Medical Sciences.
Professor Nikhil Tandon is a head of the Department of Endocrinology, and I think the entire medical and endocrinology fraternity knows Professor Nikhil Tandon, and he has been very dynamic. Right now he is a member of the MCI also and National Medical Council, and Professor Tandon is one of the person who is a very prolific speaker, and one I think the one who is full of the knowledge. So today he is going to speak about the treatment of hyperthyroidism. Professor Nikhil Tandon.
Thank you, Dr. Jingan. I was trying to ensure that technology is working.
15 मिनट बोलना है, 25 मिनट बोलना है।
ठीक कर दें। I've taken the liberty of putting the word in adults in parenthesis, realizing that a large proportion of the audience here would be, adult physicians. And again, the second thing which I've done and I've taken the liberty is primarily we'll talk to you about Graves' disease, because that's the one which is much more in terms of medical therapy. But I will refer to the other two important causes of hyperthyroidism, namely toxic adenoma and toxic multinodular goiter at the end. But this will be largely a sort of a Graves' disease related talk. Okay. So first, of course, is you need to diagnose hyperthyroidism before you can treat hyperthyroidism. And the classical toxic features, this audience doesn't need to be reminded, would be the usual ones of unexplained weight loss, irritability, sweating, tremors, sometimes GI disturbances. But I think the important thing which we need to understand here is that there is an entity called thyrotoxicosis, which is the overall universe, which is a syndrome which happens in response to excess circulating thyroid hormone, right? So when we use the word thyrotoxicosis, we actually refer to a syndrome which is seen in response to excess circulating thyroid hormone. It is not with reference to whether the thyroid hormone is coming from the thyroid gland, overproduced by the thyroid gland, inflamed thyroid gland releasing it if it's coming from some other part of the body, or it's coming because somebody is taking a large amount of thyroxine from a bottle of thyroxine. So thyrotoxicosis is a universal set. The word hyperthyroidism is traditionally restricted to when there is a sustained overproduction of thyroid hormone by the thyroid gland. So there are three things which are important to understand: that it is from the thyroid gland. So if you are taking 20 tablets of thyroxine every day and you become thyrotoxic, you are not hyperthyroid, you are thyrotoxic. Second thing is that it is an overproduction. And third thing is that this overproduction is sustained. So remember, this is important because one of the key diagnosing factors for hyperthyroidism will be if you do a radioactive iodine uptake or you do a technetium scan. Iodine is used as a substrate for thyroid hormone production. So if there is a sustained overproduction of thyroid hormone by the thyroid gland, there will be an increase in radioactive iodine uptake. In contrast, if the person has thyroiditis, which is when the hormone is being released because of an inflamed gland, it will not show an increase radioactive iodine uptake or will not show an increased uptake on a technetium scan. So please just remember these two terms. It is important to not use them interchangeably. All hyperthyroids are thyrotoxic. All thyrotoxics are not hyperthyroid. So I think that's one message I want to give at this point of time. Biochemically, and let's keep this simple, it will be an elevated level of thyroid hormone and a suppressed TSH, which is easy to understand because the TSH, the pituitary is part of the negative feedback loop. And then, as I already mentioned, if it is a sustained overproduction of thyroid hormone, it will require increase in substrate. If you do a scan, very few people do a radioactive iodine uptake. Most of the nuclear medicine labs sort of prefer using technetium-99 as a scan. A diffuse increase uptake will be seen in Graves' disease, a focal uptake in the adenoma with a suppression of the surrounding parenchyma. So one of the classical features of toxic adenoma is that the adenoma sucks in all the radioactivity. And because it's sucking in all the radioactivity and the TSH is suppressed, the rest of the thyroid gland will not take it up, which is also a huge benefit in a toxic adenoma, because if you give radioiodine as a therapy, the rest of the gland usually does not suffer, and you can get a remnant gland will function. And the third thing is for toxic MNG, when there will be multiple areas of increase and decrease uptake. So again, very important to understand what the scan picture is like. So you're seeing a person who looks thyrotoxic, you're seeing a biochemical increase in T4, suppressed TSH. If you do a scan, you can differentiate the three main causes of hyperthyroidism. There's one thing I will now mention on several occasions during the course of the talk. It was not something we used significantly in the past, and that was the TSH receptor antibodies of thyroid hormone, TSH receptor stimulating antibodies, which are the pathogenic antibodies in a person with Graves' disease. Obviously, these are, because it's an autoimmune phenomena, they will be negative in all other causes of hyperthyroidism, right? So TSH receptor antibodies were not usually available, and we had very limited utility of those. There has been some change in the use of antibodies for management decisions, and I'll come to that a bit later. So initially, all that we used these antibodies were, if and when they were available, was predicting risk of neonatal hyperthyroidism in a woman with past history of Graves' disease. So supposing there's a patient, she has had Graves' disease, which has been taken care of. So she's in remission, or she had a thyroidectomy, or she had radioiodine ablation, but the autoimmune phenomenon is persisting, right? So you may still have elevated levels of antibodies which will cross the placenta and may cause neonatal thyrotoxicosis. And similarly, a person with Graves' disease who's pregnant while taking antithyroidal drugs will again be in that scenario. So it was a very limited utility of the TSH receptor antibodies. Today, we have started looking at using these antibodies to help us decide when to stop antithyroid drug therapy, and so that I will cover this in some detail as we go along. So the treatment of Graves' disease can be in two ways. This is medical management, disease specific and symptomatic. Symptomatic is usually with beta blockers, and that is given in the early part of therapy till such time that the antithyroid medication has suppressed hormone production. Antithyroid drugs invariably are the first line. Radioiodine and surgery I shall refer to in the passing, because as physicians we're not directly usually involved in that. And the treatment decision will depend on the age of the patient, how severe is the thyrotoxicosis, presence of ophthalmopathy. So acute active ophthalmopathy is not a good time to give radioiodine because it can cause a flare-up. Degree of enlargement, if there's a significant amount of enlargement, you may want to consider thyroidectomy. It's a very rare option used today, but a large gland may require a thyroidectomy. Pregnancy, and of course the patient may decide. The patient may say, I don't want anything else, just keep on giving me oral medications and I'm fine with that. That's all right. Okay, so basically the drugs which are used commonly are thionamides. Carbimazole is the prodrug. So 10 milligrams of carbimazole is equivalent of 6 milligrams of methimazole. So they're basically, whether you give carbimazole or you give methimazole, you're really giving the same product. And then propyl thiouracil, for which the number of indications for PTU have really shrunk quite significantly. So PTU we use in the first trimester of pregnancy because there's concern that the carbimazole, methimazole may cause coronal atresia or some other problems. And sometimes it may be a preferred agent during a thyrotoxic crisis. Other than that, by and large, methimazole, carbimazole are agents of choice. And the rest are really not to be used. And you sometimes end up using lithium if a person who is on thionamides develops a severe adverse event. So if somebody who has on carbimazole developed agranulocytosis, You don't want to take a chance with any other thionamide because the chances are that they will develop that. In that circumstance, if you need to control thyrotoxic features, then lithium becomes an agent of preference. Other than that, you don't do that. So again, I'm not going to take you through this whole slide except to show that methimazole has a significant half-life, but even this half-life becomes longer when so you really need the drug at the level of the thyroid, right? So more than circulating half-life, you have what is important is intrathyroidal half-life, and intrathyroidal half-life for the thionamides like carbimazole, methimazole are about 24 hours. So really, once the initial acute thyrotoxic phase is over, you can give these medicines once a day. The dose will vary. I don't want to go into anything except to say that the only concern which we have is agranulocytosis. Therefore, every prescription of these agents should contain the following. In case of fever, sore throat, oral ulcers or skin rash, please stop therapy, get a TLC, DLC done and report to your physician. A prescription of an antithyroid agent without this added sentence is an incomplete prescription. In case of fever, sore throat, oral ulcers or skin rash, please discontinue, get a TLC, DLC and report to your physician, right? As I said, by and large, these are the agents which are used more commonly. The only concern with methimazole, carbimazole is in the first trimester where you can get coronal or esophageal atresia. That's why first trimester of pregnancy you prefer PTU. Other than that, we're quite happy to give carbimazole or methimazole. Now, this is the only thing which gives us some trouble. It happens, it's idiosyncratic. It can happen early, it can happen late. There is really, it's unpredictable. So there's no point saying ki ji har hafte aap baith ke na TLC DLC karao. It doesn't help. You just have to flag that this is a problem. The concern would of course be that you can end up with sepsis because of a low absolute neutrophil count. So an absolute neutrophil count below 1500 is a matter of concern. Below 500 of course is a big problem. Stop the drug, and in some instances you need to give colony stimulating factor. But remember, this is really the one thing which is a matter of concern. Of course, hepatitis and cholestatic jaundice has also been described. Again, that will require cessation of drug therapy. So once you start treatment, what really happens? Gradually, T3 and T4 start normalizing. Usually by 3 months, you should be all right. TSH does not normalize fast. So, don't keep worrying ki TSH suppressed aa raha hai, ab kya kare? TSH will take its time to get suppressed. The feedback mechanism takes its time. So, as long as you're getting T3 and T4 in the normal range in the first 1 to 3 months, you're okay. And therefore, you need to measure a 4-weekly or 6-weekly for thyroid function. As the thyroid function returns to normal, you can reduce the dose of antithyroidals till you come to a maintenance dose. Traditionally, now you give antithyroidals for about 18 months in adults, about 36 months in children. So pediatric Graves is a tough disease to manage. Remember, they are much more likely to get into difficulty and much more likely to relapse. So you give an extended duration, but I'll come back to this 18-month business in a minute of time. Simplistically put, and these numbers are not really accurate, there could be anything, about 50% people will go into long-term remission, that is remission beyond 1 year after cessation of drug therapy. 50% of those who relapse, about 50% will relapse very soon, within 3 months, and most of them, 80 to 90% of those who will relapse by 1 year. So if somebody has not relapsed 1 year after stopping antithyroidal drugs, there is a smaller chance of 10 or 15% or 20% that they will relapse in future. Those who have to relapse will 90%, 80% will end up relapsing in the first 12 months. Now, this is an emerging concept which has also started reaching professional society recommendations, that if, let's say, you want to stop drug treatment at 18 months, right, and you get a TSH receptor antibody level done and that is elevated, it is likely that this person will relapse, right? So what is often suggested today, and I'll show you that in an algorithm in a moment, is you may want to do a TSH receptor antibody, let's say after 18 months of therapy in adults or 36 months of therapy in children, and then if it is suppressed, well and good, discontinue. If not, consider giving at least one more year of therapy. And if it still relapses after that, you may then want to consider definitive therapy, which could be in most instances radioactive iodine, in a few instances surgery. The option of long-term low-dose methimazole, carbimazole has now started coming into play. So it was an option which, if you are interested in historical literature, was mentioned in the 1950s and 60s. And then people said, nahi, jaldi karo, aar karo ya par karo. And so it ended up with 18 months of therapy, stop, remission, great, relapse, ablate. Now again, this whole business of long-term, low-dose antithyroidals is coming into play. Now, what are the factors associated with reduced remission? Men worse off, younger patients worse off, especially pediatric adolescent patients clearly worse off. Not surprisingly, large gland, high circulating levels, high antithyroidal drugs. So if you're still requiring 15, 20 milligrams at 18 months of therapy, don't even bother stopping. Very likely that this person is going to relapse. And as I mentioned, elevated levels of TSH receptor antibodies are more predictive of relapse than otherwise. This we already know, beta blockers early in the course of therapy because you want to control symptoms, and we prefer a non-cardioselective agent like propranolol, 40-BD, 40-TID, whatever you want. It's a symptomatic therapy guided by the patient's response. Right? Radioiodine therapy, as I said, is something you will consider in a lot of people. You will say that, we'll give them 18 months of therapy or longer. If they still relapse, we'll give radioiodine. But if you have somebody who's got a large gland, the likelihood of them remitting later is low. You may primarily want to consider radioiodine therapy. So give them antithyroidals, control them, stop antithyroidal therapy for 3, 4, 5 days, give radioiodine, wait for at least 2 weeks, and then restart antithyroidal therapy if you think the person is toxic, so that they don't go into a problem. So stop about a week before, restart about 2 weeks later, if at all. For women of reproductive age group, must do a pregnancy test. And the second thing, and this is an important area, and you must sort of consider this very carefully, the recommendation is that you can conceive 6 months after radioiodine. The problem is that the final outcome of radioiodine is only apparent about 6 months later. Supposing somebody has not remitted or has become hypothyroid, you'll still need more time. So traditionally, people like me, conservative physicians, will possibly wait a year before you allow the woman to conceive. We won't go into this. This is a dose relationship. Lots of stuff has been tried. People have calculated doses, given a standard dose, looked at the thyroid volume. What is increasingly being done is now give an ablative dose. So 8 to 10 millicuries destroy the gland, make the person hypothyroid, and then start the person on thyroxine. Otherwise, you can give a calculated dose with the hope that you will render the person euthyroid. But over a period of time, they gradually, a lot of them will become hypothyroid. So, 2 साल बाद होना है तो आज करो, खत्म करो, thyroxine शुरू करो. It's much simpler, much neater. So the side effects, and this we see very rarely, are radiation thyroiditis, and you can get a little pain, swelling, but that settles down. The long-term issues could rarely be hypoparathyroidism, not common but known. One thing let me tell you very clearly is that this whole business ki, will there be an increased risk of thyroid cancer? No. There is no increased risk of thyroid cancer if you ablate. So that is one thing patients normally ask, aap radiation de rahe ho, cancer to nahi hoga? No. So that's an important thing which one must remember. Surgery is very, very uncommon, very uncommon. I mean, most people will not like to get their throats cut for something which can be managed either with medication or with radioiodine. Large gland, cosmetic issues, and one more thing. You said, Doc, I want to be normal by next week. No antithyroidal, no radioiodine can do that. You want an immediate euthyroid state and a large gland, operate. But as I said, I would dissuade most people from getting operated because there's no reason for subjecting yourself to a surgical procedure with potential side effects when non-invasive procedures are available. There are, of course, as I said, indications of large goiter, failed medical therapy in somebody. So, remember, there are cultural issues. There was a time when in Japan, people never agreed to get radioiodine therapy because of the historical issue of the nuclear bomb and the radiation out there. So they would take either oral medication or surgery. So that's the historical perspective. Pregnant women, of course, with a large dose of ATD, you may consider second trimester thyroidectomy. I have never got it done, right? If there are concurrent suspicious nodules and you're not sure, and you do an FNAC and there's a coexistent nodule and you're uncertain, maybe you want to do a surgery at that point in time. And obviously damage to the recurrent laryngeal nerve and hypopara are problems. So this is, just take you through these few slides to show you some of the data on TSH receptor antibodies. Now, this was a study published more than a dozen years ago which said you're comparing a usual treatment of, a year and a half versus continuation of low-dose methimazole, and you can see that of those who continued low-dose methimazole for about 4.5 years, the remission rate was 70%, and for those who took 18 months of therapy, the standard 40, 45, 50%. So clearly, long-term therapy did seem to increase the likelihood of a long-lasting remission. This is another similar study, a second course of antithyroid drug therapy for recurrent Graves. So one course, recurrence, traditionally we've said in that instance, ablate or operate, but they've now shown data that if you've given long-term therapy, like here it was a median duration of 20 months as opposed to 15 months in a recurrent Graves, even here you manage to get a better remission rate, right? So this is a randomized control trial which was published a couple of years ago from Iran. About 260 patients treated with antithyroidal drugs for 18 months, which is a standard course. Half of these patients discontinued therapy, half of them continued low-dose therapy for the next 5, 6, 7, 8 years, right? And as you can see, very low relapse rate, so 20 out of this, about 15% relapse rates, as opposed to about 50% relapse rates. So there is now an evolving belief that it's not that if you give 18 months of therapy, beyond that is not going to give you an additional advantage. You may want to consider long-term therapy. And this is essentially showing what happens when you give antithyroidal drugs, that if you're giving antithyroidal drugs and you're measuring TSH receptor antibodies, those who are positive, 90% relapsed, those who are negative, 30% relapsed. So there is some rationale of, after 18 months, if you want to do a TSH receptor antibody measurement and take a decision whether you want to continue therapy or discontinue therapy, right? And so this is a possible algorithm which you may want to consider. Untreated Graves' disease, give it for 18 months in adults, 36 months in children. If they are not tolerant to the tablet, you may ablate. They want to get operated for some reason, ablate. Otherwise, you can stop here. If there is persistent hypothyroidism or presence of antibodies, you can then continue for another year or 2 years and then stop. So you have, from a previous obsession, कि अब चलो 18 महीने दे दिए बहुत हो गया है, to a move towards you may consider a longer term therapy, especially if you're down to 5 milligrams a day. Most patients don't bother. They can continue taking it and your long term remission rates may be much, much better. I'm not going to go into this in much detail except the issue about a woman who's in the reproductive age group and the family is not complete. I've already mentioned that in the event that you want her to be ablated, then wait a year after radioiodine. Other than that, if they do become pregnant on this, PTU first trimester, carbimazole, methimazole in the second and third trimesters. In older adults with heart disease, there is, most people say don't waste time, make them euthyroid with antithyroidal drugs, and then ablate. Finish it off. Because thyrotoxicosis, even subclinical thyrotoxicosis in an elderly patient with adults, with untreated disease is likely to become a problem. I'm just going to wrap up with these 2 slides. Toxic multinodular goiter or toxic adenoma will not go into remission with antithyroid drugs. So the message for them is very clear. Control their thyrotoxic state with antithyroid drugs, either ablate or operate. Toxic adenomas, very good candidates for ablation because, as I said, that'll suck in all the radioactivity and the rest of the gland may be normal. Toxic MNGs, especially the larger ones, possibly require surgery. Both instances, first give antithyroidal drugs, then make them euthyroid, and then do anything after that. So these are the basic options. Radioactive iodine therapy, very, very common if you are for giving toxic adenomas and small toxic multinodular goiters. And surgery, if you've got a large gland, you're concerned about compression, concerned about cancer, or concerned about, or there's of course retrosternal or substernal extension, you give it in that. Obviously, if the patient is not willing, not fit, then you can continue long-term antithyroidals with a very clear understanding they will need indefinite antithyroidals because they will not ever go into permanent remission. So I'm going to stop here by saying that, as a disease, we've sort of gone beyond the time when we used to discuss different regimens. There used to be a titration regimen and a block replacement regimen. Currently, what is being done is a standard titration regimen. Start with a higher dose, bring it down, 18 months of therapy, decide if you want to give some more, wait. In case of relapse, you may want to try and extending the therapy or give definitive at that point in time. As I already mentioned, please be clear, there is a difference between thyrotoxicosis and hyperthyroidism. One is a universal set, one is the subset. The one new message which is emerging from, let's say, 4 or 5 years ago to now is there is a role of measurement of TSH receptor stimulating antibodies in deciding treatment duration, and a long-term carbimazole methimazole therapy is available as a treatment option. I'll stop here and I'll thank you. I'm not sure if question answers are allowed.
Thank you very much, sir, for this very wonderful, such a lucid talk. And all of us, we have great privilege to able to learn from you on this platform. And I think all of us, we are wiser regarding the hyperthyroidism after listening to this, sir. Sir, the house is open for any comments or questions if you have any.
Good evening, sir. Sir, I wish to ask a question. If a young female of reproductive age group with family is incomplete, recently diagnosed with Graves' disease, and she is not willing for any radioactive iodine ablation, should I start with PTU or should I start with carbimazole?
So what I would do is, see, we don't know when she is going to conceive.
Yes.
Right? So what I would do is start with standard carbimazole, methimazole, and tell her that the moment, there is a plan for conception and then you have a pregnancy test which is positive, shift to PTU, fully realizing that, by the time the pregnancy test becomes positive, it will be around 4 weeks into her first trimester. But, I don't want to give her unnecessarily prolonged PTU also. So limit it to the first trimester. Start with carbimazole, methimazole, shift to PTU. And once your first trimester is over, please revert back to carbimazole, methimazole.
And secondly, if there is unavailability of the thyroid scan.
Sorry?
If there is unavailability of the thyroid scan, can ultrasound of thyroid helps in making the diagnosis?
So, there are 2 or 3 things. If there is a diffuse goiter on palpation and on ultrasound with increased vascularity, and let's say you do an anti-TPO antibody, which is not seen in 100% but maybe seen in 80% of the people, you're much more likely to consider a Graves' disease. Obviously, if there are other features like ophthalmopathy, because ophthalmopathy will not happen in any other cause of hyperthyroidism. So that's supporting clinical evidence. Similarly, if you're getting multiple nodules, largish gland on ultrasound, think towards toxic MNG. Remember, the clinical point here is people do not start with toxicity in a multinodular goiter. Usually older patient, usually preceding history of a long-standing goiter, which has then become toxic, right? So it's not that ki kal goiter shuru hua, आज toxicity आ गई. That goiter would be there for some time because there has to be a critical mass. For toxic adenoma, it's going to be a little difficult, but if again a normal looking ultrasound on, except for that solitary nodule, you may think about it. So you need clinical support. Obviously, you will not be 100% sure, but you may, maybe even 90% certainty you can differentiate between the three.
Thank you.
Thank you, sir, for this extraordinary presentation. I have a question, sir. Sometimes we come across some patients who have waxing and waning hyper and hypothyroidism. How do we treat these type of patients?
So these are not rare, these are not common, they have once in a while, so you have one option. Discuss with them, it's much easier, as you know, to treat hypothyroidism, right? Ablate, finish it off, and make them hypothyroid and treat them.
Thank you. Thank you, sir.
So if there are no more questions, I thank you, sir. Thank you very much
Thank
for
you.
Your time.